Okay, hi everyone, I'm Skip from YINGCHI. Thank you for attending the lecture this week. We're discussing PTSD, the post-traumatic stress disorder, this week. And PTSD is a mental health condition that's triggered by a terrifying event, either experiencing it or witnessing it. Symptoms may include flashbacks, nightmares, and severe anxiety, as well as uncontrollable thoughts about the event. Most people who go through traumatic events may have temporary difficulty adjusting and coping, but with time and good self-care, they usually get better. If the symptoms get worse, last for months or even years, and interfere with patients' day-to-day functioning, they may have PTSD. Getting effective treatment after PTSD symptoms develop can be critical to reduce symptoms and improve function. Now let's start to the main body of this lecture. These are our social media. You can follow us on this social media. Also, you can subscribe our YouTube channel to see more previous videos. So first, we will have a brief introduction to the definition of PTSD and its research status. So first, let's figure out the term TE, traumatic event, which is defined in the DSM-5 as exposure to threatened death, serious injury, or sexual violence. And over 70% of respondents reported a traumatic event, and more than 30% of them were exposed to 4 or more, and exposure varied by country, social demographics, and history of prior traumatic events. Exposure to interpersonal violence had the strongest associations with subsequent traumatic events. And as you can see in this graph that this kind of stress disorder is quite prevalent in Germany, USA, UK, and Italy. So what is PTSD? It is a disorder that develops in some people who have experienced a shocking, scary, or dangerous event. And neuromodulation is based on the brain circuit abnormalities in PTSD. And some studies reported that amygdala hyperreactive is positively correlated with PTSD symptom severity. And the majority of studies have found diminished hippocampal volumes in PTSD patients, and the insular cortex activation has been found to correlate with measure of symptom severity and post-scan plasma, adrenocorticotropical hormone levels, and insular cortex hyperactivity has been confirmed by meta-analysis. So what are the signs and symptoms of PTSD? At least one re-experiencing symptom and one avoidance symptom, 2 arousal and reactive symptoms, and cognition and mood symptoms. To be diagnosed with PTSD, an adult must have all of the following for at least 1 month, and we will explain it one by one to you. And for the re-experiencing symptoms, it includes flashbacks, which is reliving the trauma over and over, including physical symptoms like a racing heart or sweating. The patients may have bad dreams or threatening thoughts. And avoiding thoughts or feelings related to traumatic event, such as staying away from places, events, or objects that are reminders of the traumatic experiences, or avoiding thoughts or feelings related to the traumatic event. The arousal and reactivity symptoms may include being easily startled, feeling tense or on edge, having difficulty sleeping, having angry outbursts. The cognition and mood symptoms may include like trouble remembering key features of the traumatic event. They may have negative thoughts about oneself or the world. They may distorted feeling like guilt or blame. They may also have kind of loss of interest in enjoyable activities. And children and teens can have extreme reactions to trauma, but some of their symptoms may not be the same as adults. And symptoms sometimes seen in very young children, which is less than 6 years old. And these symptoms can include wetting the bed after having learned to use a toilet, forgetting how to or being unable to talk, acting out the scary event during playtime, and being unusually clingy with a patient or other adult. Some factors that may increase risk for PTSD, such as living through dangerous events and traumas, getting hurt, seeing another person hurt, or seeing a dead body. They may also have childhood trauma, feeling horror, helplessness, or fear. They may also having little or no social support after the event, and dealing with extra stress after the event may also cause some increased risk for PTSD. And some of the patients may have a history of mental illness or substance abuse. And there are 5 different kinds of PTSD, which is from the most minor form to the most extreme, such as normal stress response, and it is what occurs before PTSD begins. Events like accidents, injuries, illnesses, surgeries, and other sorts of unreasonable amounts of tension and stress can all lead to this kind of response. And the acute stress disorder, while not the same as PTSD, can occur in people who have been exposed to what is or what feels like life-threatening event. And the uncomplicated PTSD is linked to one major traumatic event versus multiple events, and it is the easiest form of PTSD to treat. And the complex PTSD is the opposite of uncomplicated PTSD, which is common in abuse or domestic violence cases, repeated exposure to war or community violence, or sudden loss. The last one is the comorbid PTSD, which is a blanket term for co-occurring disorders, and it is applied when the person has more than one mental health concern, often coupled with substance abuse issues. Comorbid PTSD is extremely common, as many people suffer from more than one condition at a time. And there are several treatments for PTSD, such as cognitive processing therapy, prolonged exposure therapy, and the eye movement desensitization and reprocessing. We may also use medications in PTSD, and TMS is also used in PTSD. And compared to other treatment methods, because electrical stimulation has a low spatial resolution and it is not that precise, and RTMS has better time resolution than TDCS. So as you can see in this graph, that to modulate the DLPFC effect on subgenual cingulate cortex, other limbic structures facilitate fear extinction via metaplastic changes. And there are different structures in the brain, and as you can see in this graph, which have different resistances and different layouts. We'll explain it after. And as what is TMS? Basically, it is based on the electromagnetic induction and uses a time-varying pulse magnetic field, which can non-invasively pass through the skull, act on the central nervous system, and produce inductive current, causes a series of physiological and biochemical reactions, thus affecting the brain metabolism and neuronal excitability, and achieve the effect of improving the treating mental and neurological diseases. The whole process is non-invasive, no need for anesthesia. This is how TMS developed in the history and as a promising technology. In 1985, Dr. Barker performed the first motor cortex stimulation with TMS, and through that, first, George et al. Has used the TMS to treat mood disorders, especially for the depression. And as for the FDA, it has approved the marketing of TMS for MDD as early as 2008. And for now, FDA has been approved for the marketing of TMS in many indications. So what are the mode of action of TMS? As for the microscopic responses, you can see the muscle twitch, and TMS can also evoke the neuronal activity and causes changes in blood flow or metabolism, and thus cause changes in behavior. And there are different stimulation modes of TMS, especially for the repetitive TMS. It has standard rTMS or the theta burst stimulation, the TBS, which has a long-term effect. And we may also apply some technologies such as 1020 EEG system and the frameless stereotactic neural navigation to help to cite or localize the desired target of TMS. TMS can help in modulate the excitability of cerebral cortex, causing long-term cortical plasticity modulation, change cerebral blood flow and metabolism, affect neurotransmitter secretion in brain tissue such as BDNF and dopamine, and stimulate the secretion of neurotrophic factors. TMS can be used in many fields such as psychiatry, which has some prevalence indications such as OCD, PTSD, anxiety disorder, addiction and craving, depression, schizophrenia, sleep disorders, and children autism. Also in neurology, such as PD, neuropathic pain, stroke, tinnitus, migraine, which is also approved by FDA, and the epilepsy, multiple sclerosis, Alzheimer's disease, and so on. And TMS is also used in diagnosis and researches. First, TMS can be used in the diagnosis of PTSD. We will not explain the definition of RMT and AMT here because I think they're the familiar terms for many of the listeners, and the motor thresholds reflect the activity of neuronal membranes and the excitability of cortical axons, synapses, and their sodium channels with NMDA-associated transmission and GABAergic mechanisms thought to be less involved. And RMT increase in PTSD patients is in the left hemisphere. And the application of a first stimulus below motor thresholds follow the second stimulus above motor threshold with a short interstimulus interval of 1 to 5 milliseconds, resulting in the physiological reduction of cortical excitability. And this parameter reflects inhibitory receptors as well as dopamine and the acetylcholine. So SICA increased in PTSD patients. A short interstimulus interval leads to an SAI, which is the short afferent inhibition, and representing a junction between sensory and motor components and leading to inhibitory effects in the primary motor cortex. It is thought that SAI may be critically dependent upon the activity of cholinergic receptors and non-alpha GABA A receptors. SAI increase in PTSD patients. And the same pulse configuration applied as long as SIS of 10 to 15 milliseconds or longer results in increased excitability. This intracortical facilitation seems to be mediated principally by glutamatergic neurotransmission, although the underlying physiology is less clear in this case. So the ICF may increase in PTSD patients in the right hemisphere. TMS is also used as a promising therapy for PTSD. And as you can see in this graph, for the post-traumatic stress disorder, the function of the left DLPFC is weakened, while the function of the right DLPFC and amygdala are relatively enhanced, leading to enhanced functions related to negative emotional processing and poor cognitive control function, which is similar to depression. And a high-frequency rTMS increases left DLPFC excitability, increases positive emotional experiences, and to use a low-frequency rTMS to reduce the excitability of right DLPFC to decrease negative emotional experiences. And the general principles are to stimulate the left hemisphere with high frequency and stimulate the right hemisphere with low frequency rTMS. This is the therapeutic schedule has shown here. We will explain it with you. And for the first protocol, it uses an ITBS protocol, which is to stimulate RDLPFC with a high frequency RTM with an excitatory effect. So in this study, 24 patients with PTSD were randomly assigned to receive rTMS at low frequency, which is 1 Hz, or high frequency rTMS, which is 10 Hz, compared to the sham rTMS in a double-blinded design. And treatment was administered in 10 daily sessions over 2 weeks. Severity of PTSD, depression, and anxiety were blindly assessed before, during, and after computation of the treatment protocol. The 10 daily treatments of 10 Hz rTMS at 80% motor threshold over the red DLPFC had therapeutic effects on PTSD patients. PTSD score symptoms such as avoidance, re-experiencing, markedly improved with this treatment. Moreover, high-frequency rTMS over the right DLPFC alleviated anxiety symptoms in PTSD patients. And these double-blinded controlled trials suggested that in PTSD patients, a 10 daily session of right DLPFC rTMS at the frequency of 10 Hz have greater therapeutic effects than low-frequency or sham stimulation. This is the results shown in this table, and in conclusion, it suggested that a high-frequency rTMS may be more therapeutically effective than the low-frequency rTMS. And in this study, 50 veterans with PTSD received 10 days of sham-controlled ITBS, which is 1,800 passes a day, followed by 10 unblinded sessions. Primary outcome measures included acceptability, the retention rates, changes in PTSD symptoms, clinician, and self-rated, quality of life, social and occupational function, and depression obtained at the end of the 2 weeks. And this is the protocol in this research. And they have found that ITBS for PTSD demonstrated feasibility and preliminary efficiency on clinical symptoms and social occupational function. These are some contradiction and adverse effects of TMS, but most of the effect is transient, which is also mild. It may disappear at the end of the day. That's all for today's presentation. Thank you for listening. If you have any questions, we can discuss about that.